Hey everyone, welcome to this explainer. If you, or maybe someone you love, are navigating an MS diagnosis right now, you already know that the sheer volume of medical jargon and treatment options can feel completely overwhelming. But today, we're going to clear that fog. We are looking directly at the clinical guidelines to distill them into a super clear framework, one that will actually help you confidently partner with your neurologist. Let's get right into it. So here's our game plan for today. First, understanding your MS treatment. Second, managing acute MS attacks. Third, disease-modifying therapies explained. Fourth, the 3 DMT categories. And finally, choosing the right treatment. Basically, we're establishing a new mental model for MS care, moving from how doctors handle sudden, immediate attacks, all the way to decoding those long-term preventative medications. All right, Section 1, understanding your MS treatment.
To really get a grip on this, we need to completely change how we think about managing MS. It helps to use a really simple mental model. Think of your treatment as being divided into 2 distinct toolboxes. Toolbox number 1, that is for putting out immediate neurological fires. Toolbox 2 is for fireproofing your house, or in this case, your brain, against future damage. Whenever you're in the clinic discussing treatments, they're almost always going to fall into one of these 2 buckets. Toolbox 1 manages the immediate crises, those acute exacerbations. Toolbox 2 is filled with disease-modifying therapies that work silently in the background so those fires never even start. Grasping this difference is absolutely crucial.
So, what exactly constitutes a fire? Well, neurologists call this an exacerbation, an attack, or a relapse. For an episode to be classified as a true relapse, you have to experience typical MS symptoms. We're talking things like sudden vision loss, new weakness, or maybe some significant sensory changes. These symptoms have to develop acutely or subacutely and stick around for at least 24 hours. And here is a vital detail. This has to happen in the absolute absence of a fever or infection. Seriously, sometimes just a simple UTI or a fever can cause old MS symptoms to temporarily flare up. But that's what we call a pseudo-relapse. It's not a true fire, and it gets treated in a totally different way. Which brings us to Section 2, managing acute MS attacks. Now that we know what an attack actually is, let's open up that first toolbox. When you have a true clinical relapse, your doctor might order an MRI using a contrast dye called gadolinium. And when you look at that scan, a brand new active MS lesion will literally light up. It enhances with the contrast. That right there is visual proof of acute inflammation. It means your immune system is actively attacking the myelin in your central nervous system at that exact moment. But before we treat it, there is a very common misconception we need to clear up. Acute medications only speed up your recovery time right now. They do not cure the disease, and they absolutely do not stop the next attack. If you're having a severe attack that's causing real neurological impairment, like trouble walking or seeing, the whole goal of Toolbox 1 is simply to put the fire out faster than your body could on its own. The clinical data is really clear on this. Acute treatments have no apparent benefit when it comes to improving your long-term disability or reducing your risk of a future attack. So what is actually inside Toolbox 1? Well, if your symptoms are disabling, the immediate game plan, step 1, usually involves a really strong blast of steroids. Generally, this is a short course, around 5 days or so, of high-dose glucocorticoids, like intravenous methylprednisolone. Though, interestingly enough, studies show high-dose oral steroids can actually be just as effective as the IV versions. But what if the attack is incredibly severe, and steroids just aren't cutting it? That's when we move to step 2. A blood filtering process called plasma exchange, or PLEX. You can think of it kind of like an oil change for your blood, filtering out those inflammatory proteins. PLEX is typically reserved for rare, highly aggressive attacks, like severe paralysis or extreme vision loss, that just refuse to respond to steroids. Okay, so the immediate fire is extinguished. Now we have to ask the single most important question for your long-term health. How do we stop this from ever happening again? And that leads us to Section 3. Disease-modifying therapies explained. Remember our second toolbox, the one entirely dedicated to fireproofing the house? These are your disease-modifying therapies, or DMTs. Unlike the short-term steroids we were just talking about, DMTs are long-term immunomodulatory medications. Their main job isn't to make you feel better today. Instead, they are working relentlessly in the background to decrease your relapse rate, slow down the accumulation of those bright spots on your MRI, and ultimately delay neurological disability over the course of your entire life. The massive takeaway here is that you really shouldn't wait for things to get worse. Early intervention matters. The clinical consensus is overwhelmingly clear. Everyone diagnosed with relapsing remitting MS should be offered a DMT as soon as possible. Accumulating data from observational studies shows us that starting DMTs early, especially within the first 5 years, significantly lowers the risk of eventually converting to secondary progressive MS. That's a stage of the disease where steady deterioration happens even without any active attacks. Simply put, fireproofing works best before the house has taken too much damage.
Moving on to Section 4, the 3 DMT categories.
What's really fascinating here is how we can take this massive, complex list of drug names and categorize them into 3 simple, understandable buckets. It's basically a sliding scale of efficacy and risk that you and your doctor will weigh together. Let's break them down. First up, we have the monoclonal antibodies, like natalizumab or ocrelizumab. These are given via infusion, and they boast the absolute highest efficacy for stopping MS in its tracks. But they do carry higher risks, including the potential for some pretty serious infections. Next, right in the middle, we have oral therapies. These are pills you take at home. They offer intermediate efficacy and immense convenience, but they come with moderate safety monitoring requirements. Things like regular blood tests. Finally, we have the older platform injections, like the beta interferons or glatiramer acetates. You administer these yourself with a shot. They have the lowest overall efficacy of the bunch, but because they've been around since the 1990s, they have the longest, most robust long-term safety profiles out there. Which brings us to our final stop, Section 5, choosing the right treatment. So, how does this actually translate into a treatment decision tailored specifically for you? Well, neurologists use a clinical decision tree. When you sit down with your doctor, the very first thing they look at is the severity of your disease. Are you having frequent, severe clinical relapses? Does your MRI show a high burden of new, active lesions? If the answer is yes, you have what's called highly active disease. And the guidelines heavily lean towards starting you on high-efficacy monoclonal antibody right out of the gate to aggressively protect your brain. But if your disease is less active, say you've only had one mild sensory attack and your MRI is relatively quiet, the decision tree branches to the other side. And over there, the choice is driven almost entirely by your personal preferences, like choosing between the convenience of pills or the safety of injections. Ultimately, selecting the perfect DMT is a process of shared decision-making. This means your values, your lifestyle, and your plans for a family are just as important as the clinical data. Yes, your doctor has the medical expertise, but you are the only expert on your own life. You have to weigh your own risk tolerance. Are you willing to accept the rare risk of a severe infection to get the absolute highest efficacy? Or does a daily pill sound way better than scheduling trips to an infusion center? Family planning is also a massive factor here, as many oral DMTs are potential teratogens and have to be strictly avoided if you're planning a pregnancy. And of course, practical realities, like insurance access and what's actually available where you live, always play a major role in this conversation. So, armed with this knowledge, knowing how to put out the immediate fires and exactly how to fireproof your future, what conversation are you going to have with your neurologist at your next appointment? You know now that acute treatments are strictly for fast recovery, while DMTs are your daily armor. You understand the trade-offs between efficacy, safety, and convenience. The biggest thing to remember is that you do not have to be a passive passenger in your MS journey. You have the tools right now to advocate for a treatment plan that perfectly aligns with your medical needs and your life. The science of MS is advancing so rapidly, and new tools are being added to these boxes every single year. So what will your treatment toolbox look like tomorrow? Thanks so much for joining me on this explainer. Stay curious, stay informed, and keep learning.